Good afternoon, friends, and welcome back. Actually, nice to see you all after such a long time. COVID has really separated us all apart. So today, I have deliberately, asked everyone to join for this lecture series. They're talking about the pyrexia during the COVID times. We encounter so many cases of fever of unknown origin. I'm getting phone call from so many doctors in and out from across the states that what is the reason, sir? We are doing the COVID test, it is turning out to be negative, and many patients are deteriorating. Some requires ICU, some require supplemental oxygen therapy. Some patient recovers on by their own. So I'll be discussing about what are the current pandemic situations we are facing right now, other than the COVID. To begin with, I would like to just make my talk and divide it into few of the important clinical clues. Now I'll be discussing about the fever with typical having a thrombocytopenia, fever with the neurological signs, fever with the respiratory manifestation. So it's very difficult for me to cover all these topics in a span of 40 minutes. So I'll just try to make it very simple, and this talk is just to help you in coming to a conclusive diagnosis that what could be the possible reason for the fever during the COVID times other than the COVID infection. So we'll not discuss about the COVID infection, but nevertheless, I'll just give you some brief ideas. Many of the doctors are the family doctors who are practicing the COVID on the outpatient basis. So we'll be discussing about. Now remember, friends, the fever with a respiratory manifestation. Now first category we're going to discuss about it. What does we are going to incorporate in this? Fever with the respiratory manifestation. The patient comes to you with the history of coryza, running nose, nasal blockage, sneezing, loss of taste, smell, cough, hoarseness of voice. There could be a dry cough, there could be a productive cough. So apart from the SARS-CoV infection, there are many common respiratory viruses which are there in the community. I have done the PCR for a few of my patients. Although I am well aware that many of these viruses do not have any specific treatment. But I was curious to know what is the reason for this. So we have found a rhinovirus, influenza type B virus, respiratory syncytial virus. So these are the common viruses in the community, which are there. So one should be very careful about it. Then why should we bother about it? There are few patients who have directly come to the ICU with a drop in the saturation, repeated, the COVID RT-PCR was negative, and the X-ray was showing some fluffy shadows, opacities which was seen. The HRCT was not consistent with that of the COVID findings. So we did the PCR and we found that the patient is already having two types of viruses. One is a respiratory syncytial virus, one is a rhinovirus, both. The uniqueness about this virus is that it can cause pneumonia. So as long as the virus is confined to the upper respiratory tract, you may have a rhinitis, rhinorrhea, nasal congestion, rhinosinusitis. When it reaches the pharynx, you may have a sore throat. When it reaches the larynx, you may have a hoarseness of voice, and then you may have tracheitis, bronchitis, and then later on viral pneumonia. Ideally speaking, other than respiratory syncytial virus and influenza and type of virus, you don't usually have a viral pneumonia. As we all know, SARS-CoV-2 induces a typical pneumonia. I'm not going to discuss this right now here. So, except for influenza, we don't use any antiviral for the other things. As you all know, oseltamivir can be started 75 mg BID for 5 days. Zanamivir inhalations are available. You can use it as an alternative in those cases where you suspect the patient could be resistant to oseltamivir. So this is very important. Now, what is the purpose of this talk, friends? When you are doing a practice in your clinic, see to it that in all the patients who comes to your clinic with a manifestation of lower respiratory tract involvement like fever, cough, breathlessness, just simply do the CURB scoring, CURB. C stands for confusion, U stands for urea more than 7 mmols, R stands for respiratory rate more than 30 per minute, B stands for the blood pressure, less than 90 systolic or cystic diastolic, and 865. So to each of these categories you assign 1 point, and if the patient has more than 2 or 3 points or more requiring ICU admission, those patients should be taken into care and consideration. That when these patient comes with a respiratory manifestation, and you must always calculate the CURB scoring system, and based upon which you are going to decide whether I should treat them on the OPD basis, whether I'm going to advise them hospitalization, whether they require ICU. The score over and above 3 definitely requires the ICU management. The score 0 to 1, you can manage it on the OPD basis. 1 to 2, they requires the hospitalization. So this definitely helps us to manage the COVID infection, the viral infection. Now friends, a very important point which I want to stress here is these viral infections are self-limiting. They may last for few days to few weeks. But if you have a recurrent symptoms, so yeah, so am I audible to all? Yeah. So suppose a patient who has acquired a respiratory tract infection and comes to you with a recurrent complaints, the doctor, I'm still having a dry barking cough. I think many of us encountered this problem in your routine practice. This is typically what we call it as a post-viral hyper airway reactiveness, or these group of patients often come under the category of bronchial asthma. Despite repeated appeal, a lot of the doctors do prescribe antibiotic. They do not have any role, friends. When you're thinking of prescribing an antibiotic to these respiratory cases, it is always prudent to obtain the sputum for culture before you initiate the antibiotic. So always take home this message that if a patient has some viral upper respiratory tract infection, now comes to your clinic with recurrent cough where the X-ray and the WBC counts are normal, just give a thought that this could be a post-viral bronchial wall inflammation leading to the airway hyperreactiveness, or this could be a case of bronchial asthma. Usually we label them and we categorize these patients as a cough variant asthma. So this is something which you should always remember. Now, what are the treatment for the viral infection other than the asymptomatic? Friends, a very important thing, the universal precaution, what is required here is wash your hands, wear your face mask, this is very important, and avoid contact as much as possible. You can advise steam inhalations. If the patient has got a rhinorrhea, you can use anticholinergic ipratropium nasal spray. You can use a typical xyloxymetazolane nasal spray for refractory this thing. If you really want to prescribe antihistamine, remember the first generation antihistamines are more promising because they are having some anticholinergic properties. So in those patients who are having a troublesome rhinorrhea, in those cases you can use a first generation antihistamine like CPM, what we are using it. Apart from it, the antibiotic has got no role. Now, very common questions you may ask, so what is the role of vitamin C, zinc, vitamin D? There are no conclusive data that these drugs are very effective, but we use these drugs as an immunomodulator. We use high dose vitamin C. There are a trial, especially in the pediatric age group, that if you initiate zinc tablet at the dose of 20-30 milligram per day, up till 50 milligram, they are found to be beneficial, and the duration of the viral respiratory tract definitely does reduce. So you can use zinc in those subsets of patients. But as far as the antibiotic is concerned, better do not use the antibiotic in these group of patients. They have got no role. If the patient with the respiratory manifestation comes after 3 weeks, as I said you, the X-ray is normal, the WBC counts are normal, this is, you must think that it is a persistent bronchial wall inflammation. You can think of giving inhaled glucocorticoids or inhaled bronchodilators. Do not rampantly use antibiotic. So this is something which is very important, which I want to tell you. So what is the take-home message about the fever with respiratory manifestation other than that of the SARS-CoV? That could be a viral infection. And always do a simple CBC, C-reactive protein and X-ray chest, especially in those patients who have got a lower respiratory tract involvement. Saturations, definitely you can monitor at home. And apart from it, think of post-viral bronchial wall inflammation. Certain group of patients, they do have post-viral fatigue which may run for weeks together. As far as you doctors who are doing an OPD basis management of SARS-CoV-2 infections, there is a new drug which has come to India now. We are using, we call it as a cocktail antibiotic. I'm talking this in regards to the SARS corona infection. This cocktail antibiotic comes at the cost of 1,20,000 per vial. You can use it to the 2 patients, but provided you must have 2 patients. Now, who are those patients? This is just for your knowledge and information purpose. All those patients who are age 65 and above, number 1. And they should be RT-PCR positive, number 1. Number 2, they should not be having any serious signs of COVID infection. That is to say, their oxygen saturation is normal. Then why should we use it? because you predict that these are the subsets of patients who are going to deteriorate. Age more than 65 years, patients who are on immunosuppressive, diabetes, hypertension, cardiovascular diseases, chronic lung diseases, so on and so forth, pregnant women, BMI more than 25 milligram per kilogram of body, meter square. So these group of patients, you can start it very early, within 7 days from the RT-PCR. This cocktail antibiotic has widely been used as an experimental therapy in US. Now it is available in India, but it is not covered under Mediclaim. So remember one thing, in remdesivir you're giving when the patient is admitted whose oxygen saturation is less than 94%, there we use remdesivir injection. Here we are giving this cocktail antibody much before the patient deteriorates. That means the RT-PCR is positive and the patient fulfills these criteria. So before the patient becomes serious, you have to use the cocktail antibiotic so as to prevent them from going into a severe form of COVID infection. So this is just for your information purpose. Now I'll be talking about the fever with the neurological manifestation, friends. A lot of cases of neurological manifestations are coming up in the northern part of India. Remember the differential diagnosis. A fever with a neurological manifestation, the patient may have altered sensorium, headache, seizures, vomiting, and even unconsciousness. These are the various manifestations, right from meningitis, meningoencephalitis to frank encephalitis. So what you should always think in your mind before you start. Any patient who comes to you with an obtundation, altered sensorium, simple, you sit with the patient, do a very mini mental state examination of the patient. This is very important. And apart from it, just try to see the neck stiffness and what we call the Kernig sign and Brud-Zinck sign. This I have already taught you all. Just see if the patient has a predominant neurological manifestation. So what should be the differential diagnosis in this current scenario other than the COVID should come to your mind. Friends, remember, one is a cerebral malaria. Second, even the dengue cases may present with the typical meningoencephalitis. Yes, there are the cases. Then comes the Japanese encephalitis, West Nile virus infection, and Nipah virus, which has been documented in certain parts of India, certain states of India, they do have it. Enterovirus is also there. Now let's give a trial that when should you suspect the cerebral malaria. The falciparum malaria, as you know, it has got affinity for the central organ, the brain. So in the peripheral blood, you may have very less amount of the parasite. They are often sequestrated. So once you see a falciparum malaria, you must be too aggressive to treat the patient because cerebral malaria carries high mortality. Dengue, as you all know, it is called as a flavivirus infection, breakbone fever. When you see a patient with dengue, very common, I'm not going to talk in detail about the dengue right now, but remember there are certain warning signs about the dengue fever. When a patient with a dengue positive comes to you with severe abdominal pain, altered sensorium, nausea, vomiting, and any evidence of third space fluid accumulation, and on the routine investigation, if you see there is a drop in the platelet, but more important than the drop in the platelet, when you see a rising hematocrit, do not forget to do a tourniquet test, which helps you to predict that the patient is going into the dengue, hemorrhagic fever, or shock syndrome. These group of patients should be advised hospitalization very soon. Apart from it, Japanese encephalitis, West Nile virus infections, few cases what I know has been reported in Maharashtra or in other states as well. I'm not very sure. Kindly check it out. So these are quite dangerous and they carry a good amount of mortality rate. Herpes simplex encephalitis, enterovirus 71 is also one of the reasons for them. So when you think of these, you must always ask for the blood ELISA level as well as the CSF PCR to do for the Japanese encephalitis, West Nile fever. The uniqueness which I would like to tell you about the West Nile is an asymmetric flaccid paralysis, which is usually seen in West Nile virus infection, and they are neuroinvasive and they carry a very, very high mortality rate. Nipah virus also it's an RNA virus. It also carries a very high mortality rate. These are the zoonotic virus. So when you do an MRI for these patients who present predominantly with the neurological manifestations, you will see the multiple small asymmetric lesions in the subcortical white matter without any surrounding edema, which is very unique. When you see an altered signals in the temporal lobes in the MRI, you think of herpes simplex encephalitis, where the acyclovir plays a very important role. But here in the case of Nipah virus, when you see asymmetric, small, scattered, multiple small, lesion, focal lesion in subcortical and deep white matter, think of it could be a Nipah virus. They carry a very high mortality rate. So cerebral malaria, dengue, viral encephalitis, well, like in the case of herpes simplex, Japanese, West Nile, and Nipah virus. And you must do even both the plasma ELISA, CSF ELISA, and the RT-PCR in order to diagnose. Last but not the least, I would like to give some emphasis to the Salmonella infection. Friends, I have 3 patients who presented with the 3rd stage of Salmonella, or what we call as the 3rd week of Salmonella. They presented with muttering delirium. They had a neurological manifestation. So never forget, if a patient gives a history of 3 to 4 weeks of fever and comes to your clinic with extreme prostration, delirium, muttering delirium and all those, think that could be a Salmonella. Remember here, friends, the culture yield as the days passes becomes much weak, and if the patient has not received any antibiotic, then the Vidal test strongly remains positive. So you must have a high index of suspicion. Bradycardia, bone marrow culture, though it sounds very simple, but it is not done in our routine practice, until the patient has not been admitted in an institution. So you obtain a blood culture. Think of Salmonella in the 3rd week, because I have few patients, and remember, once you diagnose Salmonellosis in the blood culture, you must give a prolonged antibiotic so as to prevent the patient going into the reservoir state, like gallbladder and chronic kidney disease. So with this, I just want to tell you, friends, that certain viruses like respiratory syncytial virus, influenza type B, and the rhinoviruses, dengue, cerebral malaria, chikungunya, and West Nile virus infection, encephalitis, Japanese encephalitis, Nipah virus encephalitis is quite seen sporadically. So you must have high index of suspicion. I know every doctor orders CT and MRI brain, so I've just given you some clinical clue. The most important thing when your patient comes to your clinic is obtain a very good history, examine the patient properly, look for a brief neurological examination, just try to see the signs of meningism, a Koenig sign, Zinc sign. Just talk to the patient and look for the sensorium, whether he's obtended, whether he's confused, many a times. Especially a take-home message in the geriatric population, friends, when a elderly patient comes to you, they may not have fever, especially who are diabetic, who are uremic, they may not have fever, they comes with altered sensorium. An elderly patient who comes to you with an altered sensorium, think always that this could be a pneumonia, a urinary tract infection, or an unexplained behavior, difficult to explain. Think of drug withdrawal, very common, alcohol withdrawal, or some illicit drug use. That could be one of the reason. So even we don't use nowadays, but in previous good olden days we used to use intravenous ranitidine. In elderly patient, at times it used to cause confusion. So urinary tract infection, pneumonia, drug withdrawal, and all these things has to be considered when the patient presents to you with an altered sensorium without fever. So with all this, I just wanted to give you a brief talk about what is going on other than SARS corona infection when a patient comes to you. So it is beyond my, the limitation of this talk that I'll treat you on every aspect. So this is just a talk on a brief diagnosis, that how can you come to a conclusion that this could be a unique case of a dengue, this could be a unique case of chikungunya, this could be a unique case of Japanese encephalitis. Whenever you're suspecting a neurological involvement with meningism, do order a CSF examination, and before you order a CSF examination, obtain the CT brain to rule out any mass lesion. This you should always remember. So with this take-home message, I just want to conclude my talk. So I have briefly divided fever during the COVID times with predominantly respiratory manifestation, along with a fever with a neurological manifestation. So with this, I end my talk, and in case of